very commonly seen is the multiloculated pleural effusions and the empyema. VATS is a great technique to address this problem. So, in the empyema, the most commonly seen problem is because of the tuberculosis. And we do VATS decortication and very rarely have to do a pleurocutaneous window or a thoracoplasty. So I'll just show this surgical video in case if you are interested. If you want, if you're not interested, please tell me a message. I will skip the video part. So VATS decortication for TB empyema or pyogenic empyema is done for stage 2 or 3 empyema. Even in patients with fibrothorax, the ribs are constricted, then also we can do by a camera, we go in, deloculate the cavity and drain whole of the empyema and remove all the pleural muck and do a complete debridement of the pleural cavity. Then there is a complete mobilization of the lung, which means the lung is mobilized from hilum to hilum. Now this is the anterior hilum which is being mobilized, and then the lung is released from the apex, released off the diaphragm. The diaphragm is also mobilized. The inferior pulmonary ligament is released, as you can see here, and then the posterior hilum is also released. So this essentially means whole 360-degree mobilization of the lung. You can see the inferior pulmonary ligament release and the release from the posterior hilum. And then the fissures are open. Both the visceral cortex and the parietal cortex both are released and the fissures are open. You can see the peeling of the visceral cortex and can see the underlying healthy lung. So this usually takes us around 1.5 hours to 2 hours. Most of the times, even the blood transfusion is not required. And we in our practice, if I go back at my data, look at it, the most of the times I am able to remove the chest drains after 2 to 3 days, and by the end of the fourth or fifth days, these patients can be discharged from the hospital without any drain. So this is a parietal pleura which is now being removed. So very rarely we have to convert these patients to open surgery, particularly in TB empyema. And then you can see the lung has nicely expanded and you can see all the three lobes. This is all the pleural tissue which we have excised, and this is a chest x-ray after 6 months. It is hardly can be said whether this patient had any empyema on the right side. Rarely done for chylothorax, we do a mass ligation of the thoracic duct on the right side. This is a very unique case. This lady had a TB empyema on the right side and chylothorax on the left side. So chylothorax, to address the chylothorax, we have to ligate the thoracic duct just above the diaphragm on the right side. So this patient had a empyema on the right side. So in the presence of inflammatory tissues, few millimeter thick thoracic duct was a challenge to visualize that. So we give perioperative fat to the patient and injected indocyanine green dye into the inguinal lymph nodes. And with the help of this robotic camera, we first dissected the paraspinal area. And as you can see in these dense inflammatory tissues, it's very difficult to see the thoracic duct. Then we switched on the infrared light and see how beautifully this duct is highlighted in infrared light, and then we can localize the thoracic duct and ligate it. See, as you can see, this green thing highlighted fluorescent is the thoracic duct. The dye is being highlighted in presence of the infrared light. And this was followed by routine VATS decortication on the right side. And this patient did exceptionally well, no recurrence of chylothorax, and could be discharged after 4 days. As you can see, a very well expanded lung after the decortication. Talking about other pleural pathologies like pneumothorax, it's a very common disease here in India. So the indication to do surgery is whether in case of high risk individuals, even at the first episode of pneumothorax, we offer the surgery, or in patients who have a chest drain and who continue to have air leak for more than 3 to 5 days. In case of second episode or recurrent episode, surgery is definitely an indication. In surgery, we do it by single port, go and control the source by stapling of the bulla, which is commonly seen at the apex or the apical segment of the lower lobe, and then to prevent the recurrence, we do mechanical periodicis. In my experience, I never have had any recurrence of pneumothorax after performing this procedure. The patients are usually discharged after 48 hours without any drain. So this is the size of the incision, as you can see. Bronchopleural fistula. So these patients suffer a lot. I mean, they just have a chest drain sitting there for months and keeps on bubbling, and nobody is able to remove the chest drain. This video is from a patient who had COVID infection earlier, had a chest drain, bubbling chest drain for around a month, and then he was referred to us. And during the surgery, we instilled the pleural cavity by saline and asked the anesthetist to expand the lung, and then we were able to visualize the air leak coming from the right lower lobe. These all pleural flakes were then removed and the lung was mobilized. This is the lower lobe which was being mobilized off the diaphragm. This is the inferior pulmonary ligament, pericardium, the fissure between the upper and the middle lobe. Both the fissures are open. And this was the normal area which was the source of air leak. This was stapled off. And then we again checked for the air leak. The air leak stopped, and this was followed by a mechanical periodicis. This patient did extremely well. He was also discharged after 3 days. Intercostal blocks for pain control. Very common problem in our settings in India and also I believe in African countries. Bronchiectasis, maybe congenital or because of tuberculosis. Surgery has a role. I mean, it is curative when the disease is in the localized form, palliative when the most of the diseased area removed, you cannot remove everything. The advantage is that it decreases the mucus production and decreases the systemic shunt. The criteria for surgery is that it has to be a localized disease. The patient should have adequate pulmonary reserve. The bronchiectasis process should be irreversible, and the patient should be having significant symptoms like cough, hemoptysis, recurrent pneumonia, and symptoms suggestive of shunting of the blood. Surgery like wedge resection, segmentectomy, lobectomy, at times pneumonectomy is also done for bronchiectasis or for destroyed lung because of tuberculosis. Fungal infection, aspergilloma is very common. In COVID era, we had plenty of patients with mucormycosis who also underwent lung resections in the form of lobectomy and sometimes pneumonectomy also. Most of the time these surgeries are possible by VATS, but sometimes even open surgery is required. Even while doing the open surgery, because of the VATS, by VATS we address the peripheral adhesions, so the size of the thoracotomy significantly reduced, and even the thoracotomy is required. It is a small thoracotomy and a muscle sparing one, and which has an excellent recovery. This video shows a VATS section of a pulmonary sequestration. This patient has abnormal arterial supply coming from the aorta. So this arterial feeder was stapled and the vein was isolated, divided by stapler, and then the abnormal lung was resected by staplers, and the specimen was delivered through the VATS port. Hydrated lung disease is very common in our practice, and we routinely do it by VATS. As you can see, this is the large hydrated cyst from the right upper lobe. To prevent the recurrence, we fill in the cavity. I use scolecidal agent by mixing betadine and hydrogen peroxide. Already just instill the cavity with this solution so that even in case of any spill, there is no recurrence because all these scolicides will die. Once the cyst is excised, we mobilize whole of the lung. We try to preserve the lung as much as possible. And then these bronchial communications are identified, sutured, and then a capitonage is performed. This is the post-op chest X-ray. For interstitial lung disease, VATS lung biopsy is the gold standard. We always get the answer after doing a VATS lung biopsy in case of undiagnosed interstitial lung disease. Lung volume reduction surgery has excellent outcomes because of the VATS. Earlier, it was done by open surgery. The outcomes were not that great, but VATS is fairly well tolerated by the patients with good outcomes. And so this is an illustration showing which are the good candidates and which are the bad candidates to undergo lung volume reduction surgery. The good candidate list is also a list for the indications to do lung volume reduction surgery. So indications would be a patient less than 75 years, smoking cessation and is essential for more than 3 months, less dose of prednisolone, at least less than 10 milligram per day, no significant comorbidities like pulmonary hypertension, heart failure, coronary artery disease, renal disease, and the patient should be motivated to undergo surgery with good nutritional status. Imaging should suggest that there should be an hyperinflation of the chest X-ray, flattening of the diaphragm, and heterogeneous lung disease. These patients do really well after lung surgery, after LVRS, particularly heterogeneous disease in upper low predominance and with fairly decent pulmonary function test, FEV1 more than 40% of the predicted total lung capacity more than 120% of the predicted, residual volume more than 150%, DLCA more than 20%, and 6-minute walk test of more than 140 meters. So these patients before surgery undergo extensive pulmonary rehab once they are prepared, and then LVRS is done, and they do really well after surgery. Wedge resection for atypical lung lesions commonly seen after post-transplant or other immunosuppressed state. For lung cancer, most of the times we do surgery by VATS and robotics. Tumor of any size, even involving the chest wall or the central tumors requiring pneumonectomy or a sleeve lumpectomy is done by VATS and by robotics. So depending upon the stage, lobectomy, pneumonectomy, segmentectomy is done, followed by an extensive systematic mediastinal nodal dissection in all lung cancer cases. So I just show a video of a robotic right lower lobectomy. This patient has around 4 centimeter mass in the right lower lobe. And in our country, most of the time, these tumors, lung cancer numbers are not that great and is detected incidentally when the patient has come for some other problem. In my practice, I first do a systematic mediastinal nodal dissection. That was inferior pulmonary node. Now we are doing a subcarinal lymph node dissection. We can see both the right main bronchus and the left main bronchus, and the whole of the lymph node packet is excised. And then we switch our attention to hilar lymph node. So doing a mediastinal lymph node dissection first has an advantage because while doing the lymph node dissection automatically exposes the bronchovascular structures, allowing us to perform the lobectomy with the ease. So this is the right paratracheal lymph node dissection. As you can see, the SVC, phrenic, and the zygous vein. Then we dissect the fissure, and you can see at the base the pulmonary arterial branches are visible. The posterior fissure is then completed with the stapler. And then the pulmonary artery branches to the right lower lobe are looped and stapled off. And now the other remaining structure is the inferior pulmonary vein, which was also looped and then stapled off. And now we have right lower lobe bronchus, which was also looped, stapled. We also verify that we are not taking the middle lobe bronchus. So We clamp the stapler and then ask the anesthetist to blow the lung, and we can see the very well expanded upper and the middle lobe, and then the stapler is fired. The specimen is bagged and delivered, lavage done, and also we see that there is no air leak from the bronchial stump. And do the intercostal blocks. The drain is removed after 48 hours, and third day, patient is discharged. I am a great fan of doing lung preserving surgery, and for central tumors, I would like to do a sleeve lobectomy. Was a medical student who came to us from Russia, who having a carcinoid coming from the left upper lobe bronchus, coming on arising from the left upper lobe and going up to the left main bronchus. So in order to get the clear margins, as you can see in this bronchoscopy, we might have to do an pneumonectomy to get the clear margins. So we avoided this pneumonectomy and did a left upper lobe sleeve resection. As you can see in this illustration, so we resected the left upper lobe and then anastomosed the left main bronchus with the left lower lobe bronchus. I don't have a surgical video for this patient, but this is the post-operative bronchoscopy. As you can see, a very good anastomosis of the left main bronchus with the left lower lobe bronchus. And till till 7 years after surgery, she did not have any resection, any recurrence. Lung metastectomy is done for indication when the disease is just limited to the lungs, and we can remove all the metastasis. And in this particular patient, these metastases are from a malignant bone tumor, and we did the resection by laser. The advantage of laser is that we don't sacrifice the normal lung tissue much, and there is no distortion of the lung parenchyma, which happens because of the staplers. Hyperhidrosis is a very common problem, affects around 2 to 4% population across all over the world. These patients are young individuals who have a very poor quality of life. They suffer a lot, and the problem is that nobody really understands what they're going through. So surgery is a very good option for patients having palmar hyperhidrosis or axillary or palmar plantar hyperhidrosis or palmar axillary hyperhidrosis. I usually do not do surgery for craniofacial hyperhidrosis. A very rare indication to do this surgery is when patient is having refractory ventricular tachycardia. So the surgery is often done when other treatments have failed. The results of surgery are immediate and permanent. So we have modified by technique. So this is the older way of doing this sympathectomy, where we used to just divide the chain over the third and the fourth rib without even looking at the ganglia. So the patient used to have dry hands immediately, but at times they would have lots of side effects like severe compensatory sweating over the back, chest, buttock, and the feet, gustatory sweating. Like they have embarrassing sweating, and the face become reds whenever they eat something spicy or sour. Severe thermoregulatory disorder, mental confusion, poor concentration, low energy levels, emotionlessness, cold hands, excessive dry hands. So ETS, if not done in the right way, or the way this video was done the way as shown in this video, will invite lot of problems. We have modified our way to do ETS and do it by robotic way. I do a combination of ganglionectomy and remicotomy, and fortunately these side effects are very less in my patients, and with very good acceptance by the patients. So the possible reason for side effects is wrong identification of the rib level, and if you do a sympathectomy at the higher level or divide too much. And the most common issue is that is because of the anatomical variation, you divide the sympathetic chain at a higher level. So I get referrals from all over the patients who have had underwent ETS at other centers and now having these problematic symptoms. So to reverse the side effects of ETS, I do robotic sympathetic nerve reconstruction. So I'm getting good results by doing a sympathetic nerve reconstruction. The quality of life of these patients has really improved after doing a reconstruction surgery. I do the reconstruction by robotic surgery and use patient's own intercostal nerve to reconstruct the sympathetic chain. And it's a great surgery is possible only by robotic system. We identify the proximal and distal cut end of the nerve and then reconnect the nerve by using interrupted sutures by 8O nylon. The patients do have reported a significant improvement in their quality of life after around 8 to 9 months. So any questions from anybody?
Hello everyone. Yeah, it will be a good time to ask the questions, and you can
No,
discuss any patient.
any questions so far? I have many things to show.
Okay.
So if audience has some questions, I'm happy to answer them.
So normally, sir, they ask at the end, but yeah, as they keep sharing, sir, we will keep sharing the questions with you.
Okay, so I'll go ahead. Okay. So is my screen visible again?
Yes, sir, it's visible. It's
Okay,
visible.
so now I will talk about the mediastinal problems. So mediastinum is the area between the two lungs, the center of the chest cavity behind the sternum and between the sternum and the spine. For undiagnosed mediastinal lymphadenopathy, these days EBUS is the best modality which diagnoses the cause for the mediastinal lymphadenopathy. At times the EBUS is inconclusive. Then we do a VATS mediastinal lymph node biopsy. So this is the, as you can see in the robotic video also. So by VATS, we can address all the mediastinal lymph nodes, ipsilateral lymph nodes actually. So this is a subcarinal lymph node. So the tissue is not going to be an issue if we do the biopsy by surgery. We can remove the whole lymph node packet and give it to the pathologist who can give the answer for the reason for mediastinal lymphadenopathy. So it's the same. Now the paratracheal lymph node resection. Another technique is video mediastinoscopy. Here, a small incision is made in the neck, and we can do a bilateral mediastinal lymph node sampling, upper and the lower paratracheal lymph nodes, and the subcarinal lymph nodes. This is a daycare procedure. We admit the patient in the morning, do the mediastinoscopy. Actually, you can remove the whole of the lymph node by video mediastinoscope, and there is no way that you will not get the answer after doing video mediastinoscopy. For myasthenia gravis, VATS thymectomy is done. It can be non-thymomomatous or thymomomatous. So whole of the thymus gland, including the tumor and all the peripericardial tissue from neck up to the diaphragm in between the two phrenics is removed by VATS or by robotics. So this is video shows we have done a bilateral from bilateral VATS approach, first from the left side and then from the right side. As you can see, both the thymic horns are excised. This is the left thymic horn. You can see a brachiocephalic vein underneath. I will skip the video if for the interest of the time. So this is the right side thing. As you can see, a very extensive radical thymectomy has been done. All the fat, all the gland has been removed. The latest approach now is to do it by robotics through the subxiphoid, through the midline below the sternum, through the subxiphoid space. We introduce the camera, and the beauty is that you can visualize both the phrenics at the same time, and the neck is nicely visualized. So the radicality of and the safety of the surgery is greatly enhanced by this latest approach. This is the left stomach. I put all my specimen in a bag and then remove it through that spot. Mediastinal parathyroid adenoma, nicely visualized by system EV scan and greatly done by VATS and robotics. Tumors at the thoracic outlet are robot is a great tool because this area is very delicate. This patient came to us from Singapore, thoracic a tumor at the left apex, closely abutting the left subclavian vein and the artery. This tumor was a high-grade tumor arising from the sympathetic chain. We also resected the sympathetic chain because this was a high-grade tumor, and and must be resected completely with negative margins. And this subclavian artery and vein are just behind this tumor. And because of the high definition 3D vision and wrist movement of the robotic system, we were able to do it safely. And this surgery took us only, I mean, this was a 15-20 minute surgery to do. And the patient was discharged the very next day. Resection of middle. Now we're talking about the lesions in the middle mediastinum, like bronchogenic cyst, esophageal duplication cyst. All these disorders can be addressed by VATS and robotics. Esophageal leiomyoma of any size. This is yet another interesting case of Boras syndrome, spontaneous rupture of the esophagus because of the retching or excessive coughing while the upper glottis is closed. The patient develops a left-sided empyema. The esophageal ruptures at the lower end, usually on the left side. It's a very dangerous condition and should be promptly identified and addressed. You can see a large, first we do it by minimally invasive means. This patient came to us and we sent this patient for an endoscopy and stenting first to control the leak from the esophagus. There was a large rent at the lower end of the esophagus, which was controlled by the stent. And then the patient was shifted to the OT to address the mediastinum. And this mediastinal collection was then drained and debrided. And this patient did very well and was discharged after 7 days. And the stent was removed after 6 weeks. VETS teratoma excision. In the posterior mediastinum, neurogenic tumors are very common. This was a 12 centimeter neurogenic tumor just above the diaphragm on the left side. The whole of the pleura over this tumor was excised, and these tumors usually derive their blood supply from the intercostals, which were nicely seen by the robotic system. This tumor was encasing the azygous vein, which also needed a segmental resection. As you can see, this is the zygous finches involved, which was clipped proximally and distally and divided. Resection of pericardial cyst, pericardial windows. For coming now to the chest wall, so all kind of chest wall tumors, sternal tumors, resection followed by a reconstruction if required. We address these tumors in a multidisciplinary board, where we involve a reconstructive surgeon if the tumor is very large to do the chest wall reconstruction after the resection. And very frequently, if the lesion is involving a single rib only, like this was a fibrous dysplasia of the 10th rib, and we did it by endoscopically to to reduce the size of the incision. This also was done using the endoscopic techniques. This is a very interesting patient, a benign bone tumor arising from the second rib underneath the scapula. If we would have done by the traditional way, which would have mean a big thoracotomy, dividing all the muscles attached to the scapula, lift the scapula, and then do a segmental resection of the rib. So this would have mean a great pain and deformity after the surgery. So we innovated and we went in through the robotic system from in the inside and did the segmental resection of the second rib and took away the tumor and moved the specimen by a tiny muscle sparing thoracotomy. chest wall sinuses because of the tuberculosis, or a plurocutaneous window or Claget's window done earlier for other diseases. This is a very great problem, causes social embarrassment with all these discharging sinuses. So very much discomfortable to the patient. So we do closure of these Claget's window and sinuses. The key thing is to resect all the diseased part and address the dead space, and most often to address the dead space, a muscle flap and an omentum is required to obliterate the dead space, and these patients do really well. This patient, you can see the harvested omentum delivered through the substernal space into the chest cavity, and has practically filled up whole of the dead space and cured the patient of his discharging sinus. Chest wall deformities like spectus excavatum and carinatum. Usually now the NUS procedure, we do it by endoscopic means. For trauma, drainage of pneumothorax, removal of bullets at several locations. This bullet is located in the mediastinum or in the chest wall, in the pleural cavity. All these bullets can be removed because by VATS technique only. For the fractured ribs, earlier it was that the notion was that to fix only the ribs which are causing flail segment and the patient is not able to wheel off the ventilator. So now the newer indications are coming up where even for non-flail chest fractures, these patients who have excessive pain should be fixed to avoid future chest deformity. And the pain control is really good if we fix these fractures by these plates. So immediately after the surgery, the requirement of pain medication goes away, and these patients do not end up in chronic chest pain. Plication of diaphragm, nicely done by robotics. So multiple sutures are taken and diaphragm is reposed back to its normal position. Nicely done by robotic system. Can also be done by VATS. This is the post of chest X-ray. You can see a diaphragm gone back to its normal position. So our aim is to focus on patient understanding
Uh,
and participation
Dr.
in clinical
Shaiwal, there are a
research.
few
In
questions. Do you want
complex
to take
situation,
them?
we always have a multidisciplinary team meeting involving the patient and the family members, and we put all the options on the table and then take the best decision in in coordination with the patient and the family. And we are deeply deeply involved in the research and the development of the new techniques to improve our surgical techniques. We always strive for pain-free operations so that our patients are discharged early, they go home confident, healthy in the shortest possible time. Thank you so much for your attention. I'm happy to take questions.
Okay. Sir, there are a few questions. The first is from Dr. Isaiah.
Varun?
Yes, sir. Sir, am I audible? Sir, am I audible? Dr. Shaiwal, am I audible?
Yeah.
Yeah. So, sir, first question is from Dr. Isaiah. Dr. Isaiah is from Nigeria. First is compliment on a very nice presentation. And the question is, it has two parts. How do you control fibrosis following resection of empyema? And he has clarified that what he meant was how is adhesions in the lung controlled after resection of empyema?
So after empyema surgery in young patients, I would do both a visceral decortication as well as a parietal decortication. So after decortication, so adhesions are going to form, no doubt about it. And these are very dense adhesions. So the aim of empyema surgery is to resect the lung, prevent the fibrothorax. So that is the whole aim. But yes, adhesions are going to form. And another thing which Dr. Isai has asked regarding the lung transplantation after pulmonary tuberculosis, it is very challenging because after pulmonary tuberculosis, I mean, if the patient has developed fibrothorax, it's very challenging. So it may be a unilateral lung transplant. It may be possible, and it all depends upon the individual case. I cannot make a generalized statement for this particular disorder.
But sir, is lung transplant possible for international patients? Because only according to Indian laws, only living donors are allowed. Is that
Living donors are allowed, and I don't think so it is possible for international because the government would not allow the cadaveric transplant for an international patient.
okay?
Earlier it was done, but not now.
Okay, sir. Another question is from Dr. Orona Paul. He is practicing in Nigeria. And first, again, thanks for the masterclass. And the question is, how do you avoid the laryngeal nerves while operating in the thoracic region using your robotic tools? Is the tool able to resect tumors completely if it is closely related to sensitive areas like the laryngeal nerves?
Yeah. So, a very nice question, Dr. Runa. So, the beauty of the robot is that the vision is great actually. So, even these nerves which are difficult to identify by VATS are very nicely seen with the help of robotic system. And also, we are able to do a very fine dissection because of the robotic system. So these nerves are better identified and better dealt with the help of a robotic system.
Okay. Okay, so sir, I was wrong. Dr. Isai is from Tanzania, not Nigeria. And his request is, can you elaborate more on hyperhidrosis? Because they didn't get it well.
So, it's a very detailed topic. So regarding harvesting of the lung from the animal, I think that this is still limited to the animal labs only. No, I don't see this thing in the near future that we harvest any lung and do a transplantation on humans.
Okay, sir,
For
but
hyperhidrosis, please ask me specific questions. What do you want to know about hyperhidrosis? Hyperhidrosis is very close to my heart. I'll be happy to answer this question.
Dr. Isaiah, can you be more specific about what you want to know about hyperhidrosis? So till then, Dr. Isaiah shares about the xenotransplantation, sir, organs harvesting from animals. Like for a lay reader like me, there are a lot of claims and there are a lot of news. So how far is humanity away from it?
No, as of now, for if you ask about lung transplantation, the xenotransplant is not there. So the what the Western countries are doing because the many of times these organs are not adequate, not optimized. I mean, not adequate. They are because of the trauma, aspiration, infection. Lot of the times the organs are rejected. And also, the surgery has to be done at odd hours. Whenever you get the organ, you have to do the transplant because to limit the cold ischemia time. So now they have come with this thing this is called as EVLP, ex vivo lung perfusion. So they harvest the lung, bring it to the lab, do the perfusion, optimize the lungs. So the utilization of the lung has increased a lot. And also you can do the surgery electively in the morning. So EVLP is the new tool which is coming up. It is very expensive even for the Western countries. But that has significantly improved the utilization of the organs, which is very precious actually.
Uh, so there's a follow-up question from Dr. Isaiah. Is it possible to invent an artificial lungs? Are there any research going on about it, sir?
So there are few things like Nova lung or ECMO. So you may call them artificial lung, but these are just for the transition to tide over the time. You cannot just do them permanently.
Okay. Sir, one question that I want to put, I mean, normally these get asked. So normally, a lot of our doctor partners who are attending, they see complex cases, but before
Mhm,
they do triage them, first the complexity should be that much that cannot be handled locally. Second, the
mhm,
patient should have financial means. Third, the seriousness about treatment. So they triage it like that. But the
mhm.
first thing that they want clarity on, what is the trigger? I mean, if it is possible to simplify that what is the trigger, what are the symptoms, when it gives them an indication that it is complex enough, they may or may not be sure that it should be referred abroad, but for safety and in-patient interest, they should, let's say, prepare a case note and share with you just to check if this fits the complexity criteria to be referred abroad. If you can, sir, help that. That's a very practical question, sir.
Yeah. So I think, see, the technology has made the world smaller. So we are so practically each of us are living like next door. So whenever you have a situation, you need any opinion, you can always approach us through email or WhatsApp. So I assure you, we'll answer the query within 24 hours. And so, and even they can investigate the patient or treat the patient at their own place if the technology or the facilities are available. If that the facility or expertise is not available, they can come to us. And otherwise, we can still guide them, handhold them. They can treat the patient locally also.
Yeah, so sir, at Jivo, we encourage that, when patient is complex and they do not have financial means, so they cannot make the trip to Africa, but they can always share doctor notes, which we can share with specialists like you. And
Yes.
if there is clarity possible, at least you can point them in the right direction. So that would be great, sir, in future, like the supporting. So Dr. Isaiah has clarified what he wants to know about hyperhidrosis. So
Okay.
he's asking about hyperhidrosis about the surgery.
So, okay, Dr. Saya. So, first thing, the care for hyperhidrosis surgery, the first thing is that this has to be, should not be offered to all the patients. The the patient, there should be a detailed assessment of the patient. Like he should have exhausted all the non-surgical methods of treating hyperhidrosis, like oral medication, local treatment like creams and Botox, whatever. And then only for a high-grade hyperhidrosis, I mean the hands are literally dripping, then only the surgery should be offered. Not for every patient. For mild to moderate hyperhidrosis, they should be told, okay, do the lifestyle modification and do the local treatment and then go ahead. Because whatever form of surgery you do would have some form of side effects. So you have to balance between the outcomes of dry hands versus the side effects. The patient after the surgery who has very bad hyperhidrosis will then only he will accept these side effects. And the whole aim is to minimize the side effects. We cannot just make the side effects zero. And how do we do them? We do it by properly identifying the ganglion in the robotic surgery. It is very difficult to identify the ganglia by VATS. So I normally would identify the fourth ganglion and then set the sympathetic chain close to the third ganglion and do a gray ramicotomy of the third ganglion. So this technique is offering me very good results.
Okay. And so there was a compliment. It makes me happy whenever somebody says that how much medical care is advanced in India. It makes me very happy, sir. So that's the comment from Dr. Isaiah that they're very happy to
So,
know.
so I'm very proud to say that India is 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 parallel to the world. We are not lacking in any of the technique across any specialty. In fact, we are way more advanced than the Western countries when it comes to the live donor liver and kidney transplantation.
And so many research reports now have started indicating that our success outcomes are
Yes,
surpassing even the best in
Western
US and
countries.
UK.
Yes, yes, yes.
Sir, now Dr. Isaiah, he wants to know. So basically, the question is, how many thoracic surgeries have you done in Africa? But you practice in New Delhi, so a lot of African patients must come to you. If you
Yes,
could just,
yes.
just give us an approximate idea.
So I have operated lots and lots of patients coming from various countries from Africa. So I have never, never, I'm not that fortunate that I have been to Africa personally. So, but fortunate enough to have and serve the patients from Africa, lots of them. Most of the time they have come to us for bronchiectasis, various tumors in the lung and the chest cavity.
Now,
So regarding the heart transplant, so I don't do heart surgeries. So I'm closely attached to the unit which is doing the heart transplantation. So they are doing lots of LVAD because of the left ventricular assist device or LVAD. The number of heart transplant has dropped down significantly. And to get a donor for the international patients is not possible. But yes, lots of international patients come to Max Hospital for LVAD, which has very good outcomes in heart failure patients.
okay, and so Dr. Aruna Paul wants to know the success rates of lung transplantation. Okay, it's not possible for international patients in India, but still they want to know what are the success rates of lung transplant.
So it depends from pathology to pathology. For pulmonary hypertension, the results are good. For cystic fibrosis, bronchiectasis, and other the outcomes vary from that individual disease pathology.
There are some robotic surgeries that it's not easy to do in Nigeria because we don't have the. But now Nigeria don't do bad. We don't get some kind of things. But at least I learned Indian style of medicine, and they are good in medicine. Yeah, they are good. So I joined their classes. They talk about some challenges you can encounter in your practice. That's why I'm trying to. I believe my craft. Because I feel say I learned from the best, both from all the sides, from the tropical way, traditional way, Oyibo medicine, WHO, the conspiracy theory. I don't weigh so many things, man. And medicine is not the way, we keep hearing some things. I'm sure you heard some things yesterday now. Medicine is not, medicine is a little bit scripted now. Yeah.
Okay. Dr. Kuduka, I'm confused here. So I think you shared many ideas. So what is the question? Hello, Dr. Odigo. Can you share the question? Okay, Dr. Shaiwal, there is a question from Dr. Aruna Paul, and get we get asked this question a lot. So, and I know that many times we do these joint exercises in the hospitals and us,
Mhm,
but it is driven by a lot of factors when to do it.
mhm.
In general, sir, if you can answer, like how Jivo team and like Max team can plan, and their Dr. Aruna's hospital team, that can we have occasional media camps, sorry, occasional medical camps where you come to Africa, stay a week, and run these specialist surgeries. So many times when doctors ask us, we know the answer that surgery is not just only surgeon skill, it is also OT infra, it is also
Yes,
the technical staff around it,
yes,
and everything cannot be exported. So
yes,
what we do is, sir, because as you said, the world is connected. What we do is we try to organize online OPDs. Okay, there is
yes,
a facility there where the patient details are shared in advance. We agree on a schedule with you. I mean,
yes,
doctor in Africa, they invite the patients to the OPD. You have reports in advance, and
yes,
jointly, the African doctor partner, the Jivo doctor partner, and the Indian specialist can
yeah,
counsel the patients and determine what is possible, or at
yeah,
least which can be treated locally and which actually really need to
yeah.
travel to India. But sir, what is your take on it? Like the question was asked.
This is a fantastic tool, Varun, and we are doing it already with very great patient satisfaction, actually. So the doctor together with the patient, yes, the reports have to be, sent to us beforehand for assessment, and we have a meaningful discussion.
So, sir, what we can do is like after this event, the team we can discuss with you your availability. Like let's say 2 weeks from now,
Yes,
a window of availability. We circulate it to our doctor network in Africa, and if they have relevant patients, they share the details by a cutoff date, and we can run it. Even if, sir, it's 4 or 5 patients in all, like at least that's a start. We can do
mhm,
it like 4 or 5 doctors, they bring one patient to their office, and we run it like a good project, like a good event management. So probably that would help, sir. I mean,
yes,
we'll just seek seek out time from you and share the schedule with everybody in the network. Now, Dr. Isaiah wants to know the cost of thoracic surgery in one seating. I know, sir, it will all depend on case to case,
Yes,
actually the
yes.
complexity, but it's better the answer comes from you.
So it really depends upon case to case, doctors. I know it's a very genuine question. I can understand, but for lobectomy is different, for decortication it is different, for sympathectomy it is different. So I cannot just give you a figure which covers the for everything.
Okay.
I think according to the case, maybe Varun, for each and every case, if the surgery is required, then maybe Varun can help with the cost and all.
No, no, sir. Like actually, we share it like with the hospital team, and they give the cost. Doctor gives the opinion, and your hospital team gives the
So
cost.
mostly, Dr. Saya, I'm not involved with the financial aspect. The hospital finance department and they communicated to Mr. Varun, and that way I think the financial part is taken care of.
Now, sir, another question from Dr. Isaiah is about diplomatic. Okay, Dr. Isaiah, see, we are conducting these master classes, and actually, few of the doctors in Nigeria and few in Ethiopia, they are actually in the process of discussing it with their medical council if these master classes can be recognized to be counted towards their CME. So sitting in
Mhm.
India, we cannot do much. The hospitals, they have a hospital to run. The hospital teams, doctors have surgery to perform. But you are there in Tanzania. I mean, we will support you if you discuss with your medical council. We will submit the documentation, how these master classes are being done. And yeah, it will be great. But little bit initiative has to come from your side also, because you are a doctor there practicing, you know, the presidents, etc., and the medical council. The good part about these master classes is it's easily verifiable, auditable. The hospitals on Indian side are the best hospitals in India. Like these are the hospitals, and the doctors coming are senior doctors. If I'll tell you about Dr. Shaiwal, though he shared his academic credentials, it is very difficult to become a doctor in India. Like the top 1% only, first they get an MBBS seat, and then the funnel gets narrower. And Dr. Shaiwal, he studied from BHU, uh, which is again, while only the top 1% get to be doctors, the top 1% among get to be to institutes like BHU or UCMS. Uh, I mean, when we were kids, that was typical, at least families that focus on education, engineering, and medical. If a boy or a girl was bright in academics, that was the path set by the parents for them. My co-founder, he's also undergraduate from UCMS, sir. So you share alma mater, and he did his surgery from MC. I am from IIT
Mhm.
Delhi, and our
Oh,
vision is that India has great strengths. Like China is the manufacturing capital of the world, we can be the health capital of the world. But
sure.
agents are not going to solve it. It's only doctor to
Mm.
doctor collaboration and events like this and further collaborative approaches that we have to take so that we reach more. That's why we are
So,
built. Yeah.
for further addressing Dr. Isaiah's curiosity, so this was an overall view of the thoracic surgery. Okay, so addressed for all the members, all the participants. So most of them are practicing, I mean, general practitioners. So if you are interested, we can have a specific topic in thoracic surgery for discussion.
Yes, sir.
Maybe if you want to discuss about lobectomy, or you want to discuss about empyema, you want to discuss about lung transplantation or bronchiectasis, whatever topic you choose which interests you, we can have that presentation and discussion.
So maybe, sir, if that is the case, maybe we can do a follow-up session with you after a quarter, after 3 months, on a more specific topic, sir. If if you're up for it.
Yeah, sure, sure. My full commitment is there, Varun. Nice to meet you. And please just let me know whatever you want me
I
to
think Dr. Orwana
do.
Paul repeated our sentiments that these master classes should be recognized by medical associations in different countries, and he's thanking us for this. Yes, sir, that would ensure one thing: whichever country's medical association recognizes masterclass, will the attendance would increase. There will be more doctors to interact with. Anyway, sir,
Thank you, sir.
if anybody has, I think we have overshot the time. If anybody has any follow-up questions around thoracic surgery, as Dr. Shaiwal mentioned, today it was a broad area, but if any questions about any particular aspect of it, you can draft your question, share in your Jivo work group. Jivo team will, in a structured way, get it shared with Dr. Shaiwal through his team, and we would get a response within very short time. If you have any complex cases, you can share notes as a doctor's note, and we can do before even you make a referral. We can again share, our team will again share it with Dr. Sheval, and we can give you first-hand feedback whether the patient will meaningfully benefit from traveling to India or not. Thank you, Dr. Sheval. Thanks a lot for your time.
Thank you so much, sir.
These
Thank you.
these sessions mean a lot to us, sir, and a lot to our colleagues across different countries in Africa. So, with your permission, I would like to end the session and thank you all
Thank you.
for taking time out on a Sunday. In India, that is the only day doctors get with their families.
Okay, Varun. Thank you.
Thank you, sir.